Good evening. Welcome to Temple Micah. I should say welcome to our Temple Micah Medical Center Learning Laboratory, session number 5, I think, with our wonderful group of in-house medical experts whom I'll introduce. Even before I introduce them, I want to say we're so grateful for them so generously sharing their expertise with us, their time to help our community feel both informed, be informed, and not only feel informed, but be informed as we continue through this pandemic, which is obviously by definition affecting the entire world, affecting each one of us in our own homes. So the 3 members of our community who we know so well at this point, I'll simply introduce. Dr. David Skorton is president and CEO of the American Association of Medical Colleges and Teaching Hospitals. Dr. Manya Magnus is a professor of epidemiology at the Milken Institute School of Public Health at George Washington University. And Dr. Richard Katz is the chief medical officer at Mount Washington Pediatric Hospital, professor of pediatrics at Johns Hopkins Medical School. Again, we are so thankful for them being with us. The evening will begin with presentations by all of them. Dr. Skorton will be moderating the panel, but we will be saving time for some Q&A towards the end. So, Dr. Skorton, David, dear friend, it's all yours.
Thank you, Rabbi, and thanks everyone for joining us again. We have not been together in a while, but the rabbi called, and you can't say no to your rabbi, correct? You really can't. So we're very, very glad and honored to be here and to share some thoughts. If I was going to describe the pandemic in just one way, one word, I would say unpredictable is the word that comes to mind. We know that these kinds of things come up from time to time. We don't know exactly when, exactly what the microbe is. And this pandemic has surprised us, as we've talked about in earlier sessions, in many ways. A large number of people could carry the virus without being symptomatic whatsoever. And then many other things surprised us about it. And lately we're being surprised, and perhaps more than a little unsettled, by the mutations that occur in nature that can cause what are being popularly called variants in the actual virus itself. So at this stage of the game, we've been dealing with this for over a year. Many of us are getting pandemic fatigue, COVID-19 fatigue. Fatigue from the fear, fatigue from being separated from our loved ones, fatigue from the very unusual precautions that we have to take, and also fatigue from not knowing, what's going to happen next. And I want to acknowledge that, and I want to also tell you that our colleagues on the front lines of the medical fight, people like Dr. Katz, are also under enormous amounts of stress. And we've seen that come out in difficult ways for those training in the fields of medicine and for those practicing medicine, and not just doctors, but other members of the healthcare team. As we are moving into the vaccination era, slowly but with acceleration, one thing that many of us thought about and many questions arose is once we've had our vaccine or vaccines, do we no longer have to wear a mask, stay socially distant, and do all of these public health mitigation efforts? And for the foreseeable future, the answer is yes, you still have to do that. And we'll have a chance to talk and answer questions if you have them about that. The stress on the medical system has been enormous, not only on the individual people, but on the capacities of the health sciences centers that have been actually not only on the front lines, but defining the front lines of the fight against this pandemic. And it got so bad a few months ago that a few places in the country implemented what you may have read about or heard about called crisis standards of care. And every hospital and every municipality has something like crisis standards of care in case there is a natural disaster, a tornado, like the kinds of things that are happening in Texas now, in which we have to figure out a way to do the greatest good for the greatest number, as opposed to dealing with people just one by one as they come into our attention. However, now, to my knowledge, no systems anywhere in the country are operating under these crisis standards of care. But that just shows you how tough it got during this, that we had to have a different way of triaging, if you will, who got care and how that care was given. And then finally, I will tell you that I personally have a growing sense of optimism about the future. The vaccines and their very, very impressive efficacy, let alone the speed with which they were developed, gives me very, very strong optimism for the future. And I do want to have a tip of the hat to those unsung heroes who worked in medical research labs for over a decade and a half to get to the point where we even had the concept of an mRNA vaccine. Not a vaccine that is actually the virus, but a different approach to doing it. And that concept, that platform, allowed industry and governmental bodies and universities to work together to develop these vaccines, Pfizer, Moderna, Johnson & Johnson, and others, in a time course that wouldn't have been possible. But I do want to say that it's not just the things that you've heard about in the last year, but the medical research that went on years before. And it's something that causes us to want to make sure that our country will continue to invest in medical research, even if it's basic and fundamental research, even if it's not obvious what it will be useful for, because you never know when a basic discovery in a laboratory will someday allow a phenomenon like the mRNA vaccines to occur. Now, I want to kick us off by asking the rabbi a question before we get to the medical and epidemiological experts. And one of the things that's been very, very hard is how we have had to say goodbye to loved ones who have left us in the throes of this pandemic, not able to be with them, not able to hold their hands, to kiss them, to share their last moments, and not able to actually have observances, normal observances of their passing, Shiva and so on, as we normally would. So, Rabbi Zalman, I'd like to kick us off by asking you the first question, and that is, in terms of honoring our loved departed and the fact that we can't do it in the usual way, what is the Jewish view on this? What can our history, our Torah, and other writings teach us about how we deal with a situation like this that I've never encountered in my over 70 years? Rabbi Zalman, over to you.
Well, thank you, David. The question you raise is clearly a terribly troubling one, and it's actually a question that came up this afternoon in a Zoom conference I was in with 9 other rabbinic colleagues. I've been, for the last several months, since a couple months after COVID began, I've been part of a kind of a thinking group that consists of 4 conservative and 4 reform rabbis, and 1 conservative movement cantor and 1 reform movement cantor. We've simply been meeting. We were brought together by 2 thought leaders from each movement to just think through synagogue life during this period of COVID, and then now thinking through what we might do as we can begin to think about post-COVID. But at one point, we were each asked to write down, just kind of write a note as you're going to enter the conversation, what's been hardest. And of the 9 of us on the screen, 7 of us wrote, helping people whose family members themselves are suffering illness and death. And it's, I'm going to say an awful thing. COVID is a terrible time to lose a loved one. Any time is a terrible time to lose a loved one. But frequently the loved one, the person who dies, spends their final days alone in a hospital, unable to be visited by close friends or family. Family is unable to travel to be near someone when there's distance. And then the entire period of the funeral itself, people aren't able to gather. So the question is poignant, and there is no precedent for this, really, in Jewish history. So both the reform and the conservative movements have made allowances for this by, of course, not violating hospital or health care professionals' protocols, but by doing such things as having virtual Shiva through a computer screen, just the way we are now. I've officiated a couple of funerals in this time, as have my Temple Micah colleagues. Funerals themselves are very, very, there's something especially sad, difficult, being at a gravesite where people are socially distanced wearing a mask. So even if the cemetery allows maybe 20 people to come, it's basically immediate family and a few close friends, but the group, instead of being able to kind of to huddle together to be with each other, you end up saying goodbye to the loved one, with a large group that are far apart. So everybody's taking care of each other's health. It's not at all what the very deep humanness in us wants us to have happen. Some people I've spoken with, and also there have been other difficulties. I gave a eulogy for the death of a dear friend of mine. The funeral was in Minnesota. I was there via Zoom, very, very, very close friend of both Louise and me, and we would have loved to have been there with the family. On the other hand, we've seen what's happening in part of the ultra-Orthodox world anyhow, where the health requirements aren't being honored in order to fulfill the obligation to bury the dead and to mourn. The health rules are being ignored, and the pandemic in parts of Israel has spread wildly. The coronavirus also causing a schism, a major schism, a new kind of schism in Israeli society between the secular and the ultra-Orthodox. So we're all looking forward to the time when your medical scientists will have resolved COVID, and we can love and be with our loved ones, and maybe for many have a post-COVID kind of period of mourning and honoring the remembrance. But this is one of the perhaps less talked about areas where COVID is just inducing a huge human emotional insult onto everybody that's lost a loved one. So thank you for beginning by asking us this question, because it is a hard and in some ways not as talked about feature of this pandemic. So thank you.
Thank you. And Rabbi, permit, on behalf of Richard and Manya and myself, permit us to thank you and Rabbis Baraha and Crawley and rabbinic interns and everything that Temple Micah does to comfort and lead us in good times and bad, but especially in times like this. Please know that your efforts to communicate, to rethink things, all three of you, are greatly appreciated and make a huge difference. So now we're going to turn it over to for two formal presentations by our two real experts. I'm just the moderator. And we're going to start out, Manya, I'm going to ask you to kick it off, and then when you're done, if you would kick it over to Richard, and then after that, folks, we're going to have a real good long Q&A. Manya, over to you.
Great, thank you so much, and thank you for having me. And also, just to echo what Dr. Skorton just said about my personal deep gratitude to Temple Micah. A lot of things have changed with the pandemic, but the just innovation and generosity of sharing everything that's happened has just been remarkable and really, really profound addition to this pandemic in the most positive way. So I'm just going to catch up on the vaccine dialogue. And I think there's a lot of questions. I'm an epidemiologist, so my favorite thing in the world, as you may remember, is design of studies and data. So we're going to catch up a little bit on that this time. I'm going to take you back, first of all, to the very first presentation we had with our congregation back in April. And you'll remember that the pandemic looked gripping and horrible back then in April of 2020. But then, of course, even by our second presentation in September, it had gotten so very much worse. And all of our lives were impacted here and, of course, everywhere in the world. But I'm also going to try to look a little bit at the bright side, which is back here in September 2020. Our vaccine, I like this particular vaccine tracker, it's very clear. You might recall I showed the same slide, and as of September 8th in 2020, there were really no vaccines. There's a lot of progress. It was remarkable progress. And I can't state enough that that progress was grounded in what Dr. Skorton just mentioned about the incredible investment in basic science over the last number of decades that lent its ability to come forward in this pandemic, in this time of crisis. But really, you can see here, there were really no vaccines to speak of. We were hopeful about them. Now, here we are today. This was actually yesterday. You can see now we have 108, million cases. We have 2 million cases, 2 million deaths here, and it's in the globe. It's been profound in the United States. Of course, 27 million cases in the United States. So obviously, we are following these growth curve of pandemics, and pandemics do what they do, but we also do what we do. And here you can see just several short months later, here is our vaccine tracker today. And I really have had the privilege of being a part of one site for one of the studies of the Moderna here at George Washington University, which was really probably one of my great privileges as an epidemiologist to be part of that in some small way. I'm a very small part of a big problem. But I can tell you that this is really an incredible testament to the ability for us to science our way out of this problem. The fact that we have not only 2 vaccines that have an emergency use authorization in the United States, there are other vaccines that are being used elsewhere in the world. We also have incredible testing technology. All of these things are going to help us really combat this virus. It's also important to notice here that we have others to watch. The Coronavirus Prevention Trials Network, which is part of the National Institutes of Health and Operation Warp Speed, which has funded other studies, and those are really coming to fruition. Ones to watch in the next month even include J&J, AstraZeneca, and Novavax and Sanofi are other platforms that are not far behind. So I want to really highlight that this is incredible, and to think that we were able to leverage this incredible preclinical work, particularly with mRNA vaccines, as Dr. Skorton mentioned. This really was leveraging of a platform to address a problem. But in addition, there are new adenovirus vectors happening. Those are some of the J&J vaccine, for example, where the virus will be tricked into our system in a way that can never infect us, but can try to teach our bodies how to react effectively against it. And there are also recombinant vaccines on the horizon. So I want to address one of the main questions I hear when I speak to community groups, which is how on earth could this have happened so quickly? And is it safe because of the rapidity of this clinical trials infrastructure? Can we trust these vaccines? And I want to explain a little bit how it works, because I think that's important. So these platforms really were developed over many decades of basic science, but they were already in testing for other viruses, not dissimilar to coronavirus, the COVID-19 virus. Those include the original SARS back in the early 2000s and MERS as well. So some of these scientific advances and even clinical advances were already underway when we got hit last year with the COVID-19. The globalization, the sharing of information has been critically important. Some people have said that it was the sharing of the knowledge of the genome early on in January last year was what facilitated the rapid implementation of the mRNA vaccines. And so they were able to translate known technologies with new viral information. And that is why we could do this. I want to make a little side note that that's going to help us when we think about the new variants. That part of the reasons we can think that the new variants can be addressed is because it's the same process we've already done so far. So we know that we have 2 approved vaccines with the mRNA version, and that really those were developed because we knew about the genes. We're going to learn about the variants, and we're going to make changes as needed and implement new vaccines in the future to address the evolution of the virus. So I really like to think of it as an overnight success that took decades. It didn't just happen in the last year, it happened before. I want to highlight what it usually looks like and contrast the clinical design of what we've been dealing with COVID-19, because I think seeing them side by side helps inform how much different this really was. Now here we have the typical, this is an FDA-based process, the Food and Drug Administration clinical trials process in the United States. And you can see here in the blue, that's the drug discovery and preclinical phase. Then we have early, middle, and late phases basically of clinical trials. And you can see here that phase 3 clinical trials usually have about 1,000 to 5,000 people in them. in a typical clinical trial modality, and it takes 6 to 7 years to get to that point, and then it's reviewed, and then there's scale up, and then post-marketing surveillance. But I want to contrast that with this. This was the Pfizer vaccine. This is actually pulled from the FDA submission that's just publicly available if you're interested in seeing it, for the Pfizer vaccine. And you can see here that their same clinical trials processes took place, but they took place on a compressed schedule. And there in the back, you can see that manufacturing was happening alongside it. Now, that was, of course, a risk. If it didn't work, there'd be a problem, but it did work, so that was helpful. But this is partially why you can see there are no skipped phases, but rather they happen sort of in concurrence. Now, you can also look at the sample size. Then in the phase 3 trial, there were 44,000 people in this trial. And these types of studies are based on sample sizes derived from how many events happen. So for better or for worse, the more cases that happened, the more epidemic was raging. That facilitated the rapid figuring out whether these vaccines would work. So that is partially why these things could be expedited so much, but not that any critical clinical trial steps were missed. Just for addition for completeness, here's the Moderna, which is the same type of paradigm. They were laid over each other and rapidly pushed forward. Now, I do want to mention that it's a little upsetting, because in my life, usually I can give a lecture and just say yes or no. And I already can tell that the questions we're going to get are mostly not. They're mostly like this. Most answers to the coronavirus questions, besides the safety question I just presented about the clinical trials, actually kind of look like this. There's a lot of if, ands, or buts, and a lot of individualization in terms of what people can and should do to stay safe. And I wish it were more straightforward. But I think it's important to understand that within this whole process, as I've said before, and I'm sure many others have as well, there are really rapid changes to what we know, and science is built on change. It is natural to change, not something that we know today is locked in stone and will stay forever. Not one vaccine is locked in stone and will stay forever. But we are showing that despite the fact there are no easy answers, we're really showing that we can work our way through this and build on our knowledge base. Some of the things that fall into this category of unknowing include the durability of the immunity brought on by vaccines, whether there'll be a need for boosters, whether specific subpopulations, elderly, children, people with comorbidities, will have different immunogenicity of these vaccines, or whether they'll have different needs for dosing or intervals. We don't know about the efficacy with the new variants for the 2 existing platforms, and there's work underway now to try to tease that apart. We still don't know about the potential for viral shedding and transmission post-vaccine. So whether someone could still transmit the virus, even if they've had the vaccine, is still under study. We don't know the long-term effects, or we don't know the effects on pregnant and lactating women or children. And all of these questions are currently under study through the globe of scientists trying to untangle this very complicated web. But I really want to say some of the things have not changed, and these things will stay throughout, which is we really have to continue to pay attention to the communities at greatest risk of the virus. And we are seeing now that so many communities have very little safety net, and this getting only worse as we get closer to the bone, closer to the end of this pandemic. And so it's up to us to really ensure we support those communities in every means possible. That includes helping them get vaccine and ensure equitable vaccine access and equitable vaccine educational materials to address health literacy and safety concerns, because equity really matters. If we only give the vaccine to some people and not all, we can't stop the pandemic, A, and B, it's obviously would be unethical. We will have to continue mask wearing, social distancing, and hand washing for the foreseeable future to protect ourselves and also to protect others. But I do want to highlight again that the vaccine is happening even if it's slower than expected. The new CDC data are coming out every day, show millions and millions of people are getting vaccinated. About 1.5 to 6 million people are getting vaccinated every day in the United States, which, although it's started up slowly for a host of reasons, it's incredible to think this much vaccine is getting into people's bodies every day as we speak. So you can keep a look at these. I look at it daily because it cheers me up. So I suggest you look at these numbers, and even though we know it's slow and maybe we are waiting for vaccines, I'm waiting for the vaccine myself. I can be reassured that my community is getting it. And then finally, again, I do want to highlight that the best time to plan for the next pandemic is now. I was very excited to hear that the current administration is taking this seriously and doing a lot of scientific surveillance activities to bolster up public health surveillance around the world. They're not defunding it, they're refunding it. And this is very, very important. We've got to keep doing this. This won't be the last. There will be more, and we must be prepared. How can we continue to do that is to elect leaders and political representatives who value science and public health. We're doing pretty well right this minute, but don't forget that the midterms are only 2 years away, and we have to keep through this. We have to keep getting that going, even though hopefully by then the pandemic will be over. Listen to scientists, physicians, and public health experts, and continue to help building the community will, the personal will, the political will to slow this virus. And I think I will stop there and turn it over to Dr. Katz. Thank you.
Okay, I'm going to share my screen, I hope. Did I get the right one this time? So thank you, Manya. This is an interesting time. I liked it that Dr. Magnus and Dr. Skorton were optimistic. I wish I could feel some of that optimism, but we are moving along. This pandemic will have an end, and the only way that we can foresee it ending is with the use of vaccines and maintaining our current practices of social distancing. I talk to a lot of people about vaccine and try to overcome vaccine hesitancy, and also read a lot about it. And what I've listed here are a few of the most common myths, and I'm going to bust them for you, and we're going to roll on to other questions. People have asked if they've already had COVID, do I need the vaccine? And the answer is we believe so, that it will boost your immunity, that we don't know how long the immunity will last from a native COVID vaccine. So we want people to take the vaccine regardless of whether they've had the disease. There are others, especially in some communities, who believe that the vaccines can make you sick, or that from either the COVID virus itself or something else. And to this point, we don't think that any of that is true. In fact, we know some of it's totally not true. I've heard this from one of our hospital staff, that he was not going to take the vaccine because he thought it was going to alter his DNA. I can tell you that that's impossible. And we can go into the science of that if we wish, but it will not alter DNA and will not change you or you will not develop cancer 30 years down the road because your DNA is altered. Dr. Magnus talked about this, about wearing a mask after you get the COVID vaccine. To this point, no one knows really how much disease can be transmitted by someone who has had the vaccine, but we know that people who've had the vaccine still can carry the virus and may shed it. So we're asking people to wear masks still. You might have seen something in the newspapers the last couple of weeks about the FDA recommending double masking. So most of the hospitals feel that the best way to double mask is for you to wear a mask and for the person in front of you to wear a mask, and that's the best double mask. There may not be as much efficacy in you wearing two masks unless you're wearing an N95 or some other respirator mask and then covering it with another one to protect it. Wearing two cloth masks doesn't make any sense, and wearing a cloth and a surgical mask is also not highly effective. And then we talked about whether the vaccine is safe because it was rapidly developed. That's a myth. It wasn't rapidly developed. It may have been rapidly deployed, but as Dr. Magnus said, it was not rapidly developed. And the other that we don't know yet, although there is some evidence to show that this is not yet a problem in the United States, is that vaccines don't work against the variants. Right now, there is evidence to show that both Pfizer and Moderna do work against the variants. The UK variant in particular, we don't know yet as much about the South African variant because we haven't seen that much of it in the areas where Pfizer and Moderna have been given out, but that's to be determined. We talked about the two vaccines that are out now and the two that are about to be released. The difficulty that you've read about with the Pfizer vaccine and the Moderna vaccine is that they need to be frozen. The Pfizer needs to be in highly specialized freezers, and those are only available generally in large hospitals or public health facilities that have these deep freezers. So most people now in communities are receiving the Moderna vaccine, which doesn't need the same diligence as far as its freezing capacity. People are very much looking forward to the J&J vaccine because it doesn't require, and the AstraZeneca, which doesn't require the same level of detail in terms of freezing, and the J&J in particular because it's one dose. Obviously, you know, if you've signed up or tried to sign up for vaccines, the Moderna vaccine requires 2 doses 4 weeks apart, the Pfizer 2 doses 3 weeks apart. And that can be varied a little bit. It doesn't have to exactly be those number of days, but it should be under 42 days for both of them. So as I said, I talk a lot and I've dealt with a lot of people who have significant vaccine hesitancy. And these are not every one of the questions, but these are the questions that I have been asked. The first one in particular, in hospitals, will it be mandated? And then the second, in the community, will it be mandated? And the answer is no. You know, I can tell you as a hospital administrator, I would love it if everyone in my hospital, well, I shouldn't say my hospital, I don't own it, but everyone in this hospital were vaccinated, but because it's still under emergency use authorization, we're not mandating it. Despite the fact that we mandate a flu vaccine, the flu vaccine is FDA approved and not authorized. We talked about the mRNA altering DNA. It doesn't. The question has arisen, is it made in eggs or human fetal cells? And the answer is no. And then more sophisticated questions have come in. Well, if I get the vaccine, will I test positive for COVID with the PCR? And the answer is no. And then although the drug companies are touting that the vaccine has a 90% efficacy, will it be lower than that in real life? And the answer is no, it's not going to be lower. It is exactly that. And so the outcome measured has been COVID and not antibody testing for the vaccine. This slide is a little confusing, but it talks about the effectiveness of flu vaccines by each season. And these are the number of studies. And you can see it's at best 60% effective. And yet we're mandating that. So if you do this in a pie graph, it's, you know, very little of it's effective. But if you take the COVID vaccine and put that in a comparable pie graph, it's striking. And so, you know, despite the fact it's not FDA authorized or approved, it is authorized, and we're very excited about this vaccine being effective. Right now, who's getting the vaccine? It's very clear that most healthcare workers are getting it. Nursing homes and the elderly and those who care for them are available to get it. And this is by federal mandate. And then each state has a slightly different play on this. And each hospital system has yet a slightly different play on that. Frontline essential non-medical workers are also getting the vaccine. In some states, people with immunocompromised conditions are allowed to get the vaccine, not in others. And in the state of Maryland, individuals with intellectual and developmental disabilities are allowed to get the vaccine. And all of this is true if you're over 18 for the Moderna vaccine and over 16 for the Pfizer vaccine. The question about immunocompromised is a difficult one. It's perfect to get vaccinated if you have an immunocompromised state, whether you've had chemotherapy or transplant or just generalized immunodeficiency. That really should be up to a discussion between the patient and their healthcare provider. Part of it depends on when the most recent immunosuppressant medications were given, when the patient was transplanted, and every transplant center and every immunologist has slightly different views, but most people think that the vaccine will be safe, except in certain conditions. I'm often asked, should I choose the Pfizer or Moderna vaccine? Most places and most people don't have any choice. The first and only choice is take the first vaccine that you can get. And if you can get the J&J vaccine when it comes out, or you can get the Pfizer or Moderna, it doesn't matter. Get the vaccine. That's the critical feature. Can you mix and match the two vaccines? At this point, there's no one who will do that for you. You are pretty much committed to the same vaccine in both wherever you are. Although there are some studies ongoing, especially in Britain, to look at a mismatch of Pfizer and Moderna together to see if it provides better immunity. But that's only in studies and not available to do on your own. The freezer question I think I've raised, but what comes along with that is who's monitoring the cold chain for those vaccines. There's a very specific pattern of how those vaccines are monitored as they get transported from the factories to the vans, to the airlines, back out into the community, and then being stored. And there are temperature tracking devices in that. So if any of them are compromised for any length of time, the vaccine, unfortunately, will be wasted. And then if you work in a hospital where everybody's getting vaccinated, people want to know, should you plan on taking time off after the vaccine or schedule a break around that day? And I'll come back to answer that in 1 second. And the difference between the two vaccines that we have seen is that the Pfizer vaccine both vaccines seem to have a reactogenicity in terms of giving you some relatively minor side effect. And, something is a minor procedure or a minor thing if it happens to somebody else, but if it happens to you, it's very troublesome. So, but we know that the Pfizer vaccine seems to have a little bit fewer in terms of the local reactogenicity effects. Moderna seems to cause fatigue and muscle pain and headaches in more people than the Pfizer vaccine does. And now that we have given, in our hospital, we've given both Pfizer and Moderna, we're definitely seeing that. So a lot of people, when they're scheduling their vaccine, will schedule it for their second vaccine. The first dose is usually pretty good in terms of lack of symptoms, except for some minor pain in your arm. The second vaccine is the one that will give you the most trouble. And some people are scheduling it on a Friday or a day when they have nowhere to go the following day. But the recovery is very quick. Most people recover from these symptoms within 24 hours, maybe 36. Long-term side effects from the vaccine, well, we haven't given it long enough to monitor truly long-term side effects, but in general, it's extremely rare for vaccines to cause serious effects after 1 month. And clearly, we've been giving these out now for well over 6 months. And the original study subjects, who were about 30,000 in one of the vaccines, were doing well after the first 2-month period. And I haven't seen firsthand data about those people later on now, but it's very unlikely that they're having any significant effects. And as someone said, well, there's always a chance of something, being 1 in a million. I mean, look at what happened with autism and vaccines. And let me just dispel that now. There is absolutely no link between autism and vaccine usage, despite what you read. I know of the person who wrote the first paper and who did that, and it was totally fabricated. So there's no vaccine and autism story that shows any causal relationship. And so we doubt there's going to be any significant causal relationship between these vaccines and any significant disease. But it does lead us to the question about women and children. Dr. Magnus talked about that. At this point, children aren't eligible to take the vaccine. There are some studies now. Moderna is doing a study starting at 6 months of age to get the vaccine. I know there's ongoing studies. I think they're in phase 2 of children 6 to 12 years of age. And I know I think there's some stage 3 studies going on with kids over 12. So it will happen, and probably we'll be able to see some benefit from vaccinating children sometime this summer. And I know there's a big push to try to get this before school starts again in the fall. We talked about, will a vaccinated person still need to wear a mask? Yes, because you could still carry the virus and still spread it. Will one of the future vaccines be better than these? Should I wait for it? No, because the disease is worse now than it has been, and avoiding getting a vaccine to wait for something better just doesn't make sense. Which immunity lasts longer, natural infection or vaccine? We don't know the answer to that yet. Right now, it's thought that the vaccine might, but no one knows that answer, and those studies are yet to be determined. Why is the liability for safety on the patient and not the government vaccine manufacturer institution? Actually, that's not the case. There is some liability protection for that, and it's not on the patient. So if something should happen, there's going to be a significant government protection for it. And then a question I was just asked the other day: since I've had COVID and I've recovered from it, will I be bumped to the back of the priority line? And the answer is no. You're just going to be in the same long priority line as everybody else. So no one is going to question whether or not you've had the disease when you apply for a vaccine, or question that you don't need the vaccine. They may ask you if you've had the disease, but they will not question your need for the vaccine. So, as I talk to people about vaccine hesitancy, the things that we've talked about are these hypothetical reasons. And, I constantly point out the reality of the vaccine. There are 7,000 people being hospitalized a day in the United States. A number are dying at any given time, and that people who have COVID, who get COVID, about a fifth of them are not back to baseline even 3 months post-infection, to say even if they've survived it without significant complications at the time of their hospitalization. So, when you have 83,000 cases a day, 90,000 people in the hospital, and 3,000 are dying daily, you just don't want to wait, and you don't want to hesitate to do what every scientist thinks is the right thing. I know there's lots of media out there. There's lots of social media that just have distorted this to a huge extent, and as have the administration. And so I think it's just imperative that everyone think a little bit differently about the risks of the disease versus the vaccine. So as I get to the end here, these are the future kind of questions. Will there be a need for an annual booster like the flu shot? We don't know. It's quite probable, but we don't know that yet. Can I take another vaccine with a flu shot or pneumonia vaccine? The recommendation is no, to wait at least 2 weeks between the two vaccines. That's not been studied. No one knows if there is a real danger with that, but it just hasn't been studied. So unless there's a massive outbreak of something other than the COVID, we recommend waiting for your additional vaccines. For my hospital workers, if you miss the opportunity to get a vaccine now, what happens? Well, you might be on the back of a long line, as we're beginning to find out how long that line really is. And what about, antiviral medications? What if I don't get a vaccine, I take antiviral medications? They haven't been shown to be all that effective. I mean, some of them, the monoclonal antibodies that are out are able to suppress infection, but they don't cure. There is no cure for this. And the best cure is an ounce of prevention, right? And so what are the risks if the desired temperature of the vaccine can't be maintained? We won't give it. It just won't be given at all. And people are very aware of that. And then people say, if I develop symptoms of COVID after the shot, will I be tested, quarantined, for how long? Well, at this point, the CDC this week recommended if you've been vaccinated and you've been exposed, you don't need to be quarantined, but that's only going to last for about 3 months. Following that, you probably will need to be quarantined again and probably will need to get tested. And so then the final question really is the most important one for women of childbearing age. What about the safety of the vaccine? So again, this hasn't been studied very much. There are lots of anecdotal cases of women who were pregnant and didn't know it at the time they got their vaccine and have delivered, and their babies have had no complications. There are women who are breastfeeding who are getting the vaccine, and theoretically, there's no evidence that the COVID vaccine crosses into breast milk, and so it's not likely that the infant would get the vaccine or any complications from it. And so, what we're recommending and what the American College of Obstetrics and Gynecology is recommending is obviously consider discussing this with your healthcare provider, but that in general now the sense is probably it's wise to get the vaccine. So finally, over 7,000 are getting hospitalized, 2,000 are dying daily. Please think about the vaccine. As we talked about, it's not rushed, it's not mandated, it's highly efficacious. It's safe, and there'll be another vaccine out this month, and so we should be able to get more people vaccinated. And finally, this is a photo of Dr. Salk giving the polio vaccine to his son with his wife there in the early 50s. And, you know, I love this quote of him: "Hope lies in dreams and imagination, and the courage of those who dare to make dreams into reality." And, you know, that's true for all the scientists who've worked so hard on these vaccines, starting with Dr. Salk, Dr. Sabin, and then moving on to the current vaccines. And I don't know that there'll be one hero in this like there was with Dr. Salk, but it certainly made a difference. And I think that's all I have for now.
Well, thanks very much, Manya and Richard. That was fantastic. And I only have one thing to tell you both. I hope you won't be disappointed. Despite your fabulous exposition of all these facts, and Richard, despite your very careful delineation of a lot of questions, believe it or not, from our colleagues in the Temple Micah congregation, we have many, many more questions.
Oh, shocking.
So take a deep breath. I hope you're feeling energetic. We got a lot of work to do, friends. So I'm going to start from the top. Deborah Winter, our wonderful colleague, has been sending me these all the time you guys have been talking. I won't tell you how many there are because I want you to feel positive about your prospects this evening. So I'm going to start from the top and we'll take it from there. I'm going to toss the first one your way, Richard. I'm sorry not to give you a chance to rest up after your most recent presentation. Please talk about the increase in multi-system inflammatory syndrome in children. What ages are being impacted? If you could start by just defining that, please.
So multi-system inflammatory syndrome in children is a severe side effect or sequela of the COVID virus. This it's really surprising to those of us in the pediatric world that this happened. The children have organ systems ranging from cardiac to eyes to pulmonary, where they get involved and become very ill very quickly. And early on, it was almost nearly fatal. We figured out now that some of the problems with this are much like in the adult world, is that anticoagulant medications seem to work to prevent the clots that occur with this disease. Putting the children on ventilators is not the answer necessarily, but it is monitoring their lung function and their overall medical status. Putting them on secondary antibiotics because they might have other secondary infections is being used, and steroids seem to be highly effective. So it's not the same killer that it was last spring. And as Manya said, we're living in real time and science is evolving. And because we learn on the shoulders of our colleagues that we can pretty much contain this now. Although, as you know, that we've had these surges, it keeps coming back, it keeps recurring, and there's been a recent surge of it. And hopefully, almost all the pediatric ICU doctors and emergency rooms now know how to recognize this and treat this very rapidly. You're on mute.
Oops, thank you very much. I thanked you already, but I'm thanking you now that you can hear me. Manya, what about flying on a plane after being vaccinated? What about other kinds of public transportation? A lot of those who are perhaps beginning to think about going back to work have to take, wherever they're living, a local metro or a bus. What's your point of view on trains, planes, and automobiles, so to speak?
So that's a great question. That goes in my category of the very complicated yes, but I think we are in a situation where we have to really accept that there are people who have to go back on various forms of transportation. I myself love the metro. I can't wait to get back on the metro, as odd as that sounds. I think, though, that all of our public health interventions are critical. We cannot stop doing those. So maintaining distance, hand washing, definitely the masks, those are critical. And we can't stop doing those no matter what. I personally am trying to minimize my metro, but not everybody can. And for many people have to fly and people have to do work. I'm probably going to put our daughter on a plane in a couple of weeks and she's going to go on a plane. So I think in my world is an HIV world. So I'm going to apply a harm reduction mode to this, which is you have to look at the situation. You have to look at what you have to do, and you have to minimize risk to the extent possible. I don't think we're at a point where we could say everyone should keep staying home, because people have to go back to work and they often will have to ride in public transportation. But if you can minimize that, if you can go at not rush hour times, for example, If you always do the non-pharmaceutical interventions, such as mask wearing and social distancing, those will be very helpful. But I would also say these depend a lot on individual risk, that if you're immunocompromised or you're recovering from cancer, then you should not do those things. But if you're young and reasonably healthy without comorbidities, and you don't live with someone who's perhaps vulnerable to COVID, then you might make a slightly different decision, but it must be engaged in thoughtfully. I don't think there's an easy answer or yes or a no. But I'm interested in both of your opinions, though, because I think this is the central question of how do we re-engage after these shutdowns.
From my perspective, what you said is exactly right. Richard, anything to add on that one?
No, I agree. As I said to my team in the hospital, I said it's easy to shut down. It's easy to be very restrictive. As painful as that is, it's easy to do. It's the return to normal that's very, very hard, very difficult, and it's going to go stepwise. And some people, I've had to fly for a couple of times for medical reasons for my wife, and I've worn a mask and a face shield, and there's no reason to think I still won't do it, even though I've been vaccinated. But yet there are other people around, because there are other people around who are sitting and eating and not, they're sort of following the rules, but not completely. So you still have to be very, very careful.
And it's interesting that I interact a lot with other association heads, and most of us have been lucky enough to have workforces who can work from home. But that's not universal. Even then, what you both said, thinking about coming back, is very important. Following up on this, I'm going to toss this one to you, Richard. We want to visit with our grandchildren in California after we've been vaccinated. The parents are already vaccinated. What is the risk here? And before you answer this, I just want to say there's a famous line in Fiddler on the Roof where Tevye is singing that song, If I Were a Rich Man, and he's talking about how they're going to ask him tough questions that would cross a rabbi's eyes. So, Richard, please take that one.
So it not only crosses the rabbi's eyes, it crosses the doctor's eyes and a grandparent's eyes. So, I'm going to tell you, I can only, let me be careful with this. I'm going to give you the advice I'm giving myself. And I don't know how scientific this is. If I were a public health expert, they might say otherwise. But when my wife is vaccinated and I'm vaccinated, we are going to go see our grandchildren. Now, our children won't be vaccinated, but they have been pretty well quarantined. Our grandchildren are not there. We're going to go. We both have decided we think we're as safe as we can be. The vaccine should be at its peak within the first 3 months of us getting vaccinated, and we ain't getting younger. And so, we want to take this opportunity. Now, would we do it again 6 months from now? I don't know. Will the vaccine still be efficacious 6 months from now? I don't know. So we're going to take that opportunity now. So, I'm only can tell you what I'm doing for myself. There are other people who tell you don't bother, don't risk it, and don't do it. But that's what I'm going to do.
And it's interesting, both of your answers point out the very crisp importance of a non-crisp answer, and that is your own tolerance for ambiguity and uncertainty. There's no perfect answer to this. So you're going to take a chance, God willing, you're going to be perfect, but there's no perfect guarantee on this. A very tough one. Okay, now here's a really, really a tough one. When, if ever, do you see it as becoming safe or appropriate to have any group activity such as a service or a meeting in the temple building? I'll take the first stab at this and then you guys can tell me what you think. I would say the time will come, but we're not there yet. Manya, Richard, your comments?
Yeah, we're not there yet, and I don't know when we will be. As we talked about as we were preparing for this, we had slightly different opinions about when it would be safe to recongregate. I was about to plan a national meeting that I pushed off now for a year and a half, and we pushed it off to October thinking that was totally safe. Just last night, we've elected to push it back again another 6 months because I just don't know that enough people have been vaccinated to feel comfortable sitting next to someone who may or may not have been vaccinated. So it's going to be a tough question. So it's going to be really difficult for the congregation. And, we talked about, could we do some sort of hybrid? I think both Dr. Skorton and Dr. Magnus suggested that. I'm not crazy about that idea, but, I wouldn't be opposed to it if we could figure out a fair and safe way to do it. And the key is safe, and no one wants to go to pray and feel unsafe. As I said earlier to everybody, everyone's weary, but they're also wary. about, the people who are right in front of them.
And I suppose there's a difference between a normal Shabbat, Oneg Shabbat service and a High Holy Day service where you'll be really crowded into a room. Manya, I thought we lost you for a moment in terms of the video. No, that's okay. Anything you'd like to add to Richard and my non-answer?
No, I think your non-answers were my also shared non-answers. I mean, I think that's what's going to be interesting. And I think one thing we can do to help people is evaluate risk individually. And there are going to be times when some people can do things that other people can't. And we see this with the school reopening where little kids are being allowed to go back to school and older kids not so much. So I think understanding these changes and accepting it's very dynamic and working with people to make internal decision-making tools, which is not like I'm writing the metro every single day, but I'm writing it one day. I'm not going to go to every service, but the high holidays are really important to me and it's going to be socially distanced outside. Maybe I would. But I think that conversation is going to have to be really instilled in all of us, not just for the next year, but forever.
The rabbi just asked me a question directly. I don't know if you all both got it. Is what is the impact of the duration of the efficacy of the vaccine? How does that impact my answer? And it does impact it because I know now that the vaccine I got last month is only going to be good probably for a good 3 months. But you don't know who got the vaccine before me or who got it after me. And so we won't know that. And so that's why I think it's still very much of a risky question.
Was that Rabbi Zemmel snuck in with that question?
Yeah, we have this relationship.
Please please, Richard, don't encourage that behavior. You're just reinforcing bad behavior. Now, this is a very interesting, very thoughtful question, I think. Many people I know who have been vaccinated are aware they have resources, time, IT savvy, etc., that others may lack. What can each of us do to pay it forward after we've been vaccinated? It's a very interesting question. I'll make 2 quick comments and then leave the real wisdom to Manya and Richard. We were not ready for this pandemic, in my view, and part of the reason we were not ready is that it's very hard to pay it forward in terms of expenditures, planning for the country, or for even individual people. How many of us wish we would have, saved more money or done something different toward the future? And not the strategic national stockpile, in my view, nor an active pandemic response playbook was in effect when this thing hit us. So one thing is be active at whatever level you're comfortable being active, locally, politically, whatever, to say, let's look forward to all the things we have to do to prepare for the next pandemic or the next event that's disruptive to society. And one of the things that this has taught us is how poorly my generation, I'll blame my generation, has done in dealing with health inequities. And we have such health inequities in our country, the richest country in the world. And we're seeing the result of those long-standing inequities in who gets sick, who dies, who has access to the vaccine. Right in our fair city of Washington, we're seeing examples of that. So I think there's any number of ways to do that. And Rabbi, if there ever was a time where you wanted to organize a little skull session where we could think about this together, I have some ideas that I'd be glad to share in terms of community engagement. Manya, Richard, your thoughts about this?
Well, hospitals are trying very hard to broaden their outreach. Unfortunately, not only were we not prepared for the pandemic, we weren't prepared for the distribution of these vaccines either. Yeah. This was a monumental mistake in terms of how it's been distributed, and sending it to the states and then to the hospitals to deliver this. Hospitals are not designed as public health institutions. Hospitals are designed for illness, and our forte is to treat and prevent illness, but not to vaccinate and not to do public health. But that's where we are now. And so, every hospital's tried to reach out to the community, tried to talk to particularly communities of color where the vaccine hesitancy is tremendous. And so, we're all trying to reach out and do that, but that doesn't help people who want to get the vaccine. It's very, very difficult. There's no good answer to this other than in some states where people have just lined up brought their lawn chairs and sat outside for 6 feet apart for hours. And that's not the way this should be done. But we're so far into this now that we're waiting for more and more vaccine to be delivered, and we didn't order enough, we didn't prepare enough, and so we're just playing catch up. And this is really unfair to everyone. I'm very lucky to work in a hospital to be able to get a vaccine, and our hospital just got a little bit extra, and we're trying to figure out how best to distribute it. We've given it to everybody we think in the hospital who wants it, and it's only 70% of our hospital. So we've got extra vaccine, and we're not going to let it go to waste. So we're going to give it to whomever we can who meets the Maryland criteria. Maryland has strict criteria for this, so we're trying to do that.
Thank you. Manya, anything you'd like to add to this?
I think this is such a thoughtful question, and it's huge, and it would really warrant some deep thinking about how we could address this in a sort of a bigger scenario. But I think there are really two things I just want to add. One is that these problems, this health inequity, is so clearly existing for so long. Many people are like, oh, wow, this just happened for COVID. Don't realize that the same thing happens every year for flu. If you look at asthma treatment, if you look at diabetes treatment, if you look at all the comorbidities, if you look at cancers, there's disparities up and down that are the same disparities really representing structural racism and a host of problems in inaccess to healthcare. So this is not a new problem. So maybe this is a chance we can, fold back the curtain and say, let's look at how this has been a product of our really bad healthcare system for the whole time, and how we can try to improve healthcare. So getting people health insurance is one thing, and obviously helping those types of safety net are critically important, not only in healthcare, but also just food and rent and all these things. But I think another thing that I think really is just a mind shift, which maybe this could help, but I'm not sure when I look at some of the dialogue on the news sometimes, but is really saying that I cannot be safe in a society where COVID is everywhere. So I can't think only about myself. I have to start thinking about the society. And the same thing is true about not just infectious diseases, but basically everything, which is everybody will do better if everyone is healthier. That the health would happen by, in Anacostia, the health of people there affects me and my health affects them. But I'm sitting here with all the resources, and how do I share that and shift that map to embrace every zip code and every population in all these things. So I think shifting our thinking about it is a critical step in order to try and to start getting some of those inequities. But they're not new, I guess, all to say. This is the same problem we see in everything, and certainly in HIV, this is exactly the same problem. And it's horrible, and maybe we have a chance to change it.
It falls in the category of tikkun olam, right? That's what we need to talk about. So just to those who are watching this, I want to point out that these two beautiful people who are talking to us, Manya and Richard, are also showing an example of the two kinds of thinking that have to be brought together: medical care thinking and population or public health thinking. And unfortunately, I want to say that for my generation, these two sectors of making us healthy did not know much about each other and didn't talk much to each other, with rare exceptions of somebody who has an MD and an MPH or something like that. But it's a great question. We're heading in that direction. I want you to keep your answers long and thoughtful, but I do want to tell you that we have we actually have quite a few questions, but we'll just pick out the good ones, do the best we can. We'll try to keep the rabbi's questions out of these if we can, till we've covered all of the paying customers. Thank you very much. Now, here's one. I'm not sure which of you might have the answer to this one. Can you comment on new treatments coming out of Israel and being tested in Greece? Reports show remarkable success. I'm not aware of that one, being tested in Greece. Does that ring a bell? Okay. I have a lot of friends in Israel, as many of us do, and I haven't heard about this one, but I'm going to look into it. Okay. Let me keep going here. I'm going to gloss over ones that are similar to ones that we've answered. Richard answered that one already. Okay, here we go. Once we are past the 1A, 1B, and 1C population, with those in phases 2 and 3, will they have a difficult time finding a vaccine? Or if I could paraphrase that, will we catch up by the time we get beyond? I'm very fortunate to live in DC and to be an old codger, and so I was able to get vaccine based on those two attributes, as well as being a physician, but I waited till my age group came up. What about by the time we get to 2 and 3, Richard and Manya, will we have enough vaccine that it'll just be easy to get, or will we still be queuing up in an uncertain way? Richard?
Well, that really is the question. And, it depends on how fast the production can ramp up. And I know we've been promised by both Moderna and Pfizer to ramp up production. And when the J&J vaccine comes out, that should make a huge difference. But I don't know that that's the whole problem. The problem is just the way things are set up to access the vaccine. Until, I don't know what happens in DC or Virginia, but I know in Maryland, there's not a unified way to register for vaccines. You go from site to site to site to site and, hope you hit a lottery win with that. So unless that changes, that's still going to make it difficult. I know the state of Maryland is opening up sites in Prince George's County and in Baltimore City at the Convention Center and M&T Bank Stadium, but they can open up the sites all they want, but we need the vaccine, and we can't control that. We can't ramp that up, although, we can't, but we hope it'll be out soon.
Manya, anything to add to that?
Just that for those of you who do live in Virginia just on yesterday actually just released their statewide registration system. So if you're in Virginia, you should sign up in that system, even if you are in a local, because they have just overcome that problem. And I think that's a central problem. I just feel like it's not it's a big problem. It's also not rocket science. So I hope with all this additional political will and money to get these vaccines in arms, hopefully it will work. And J&J will help for sure. That goes without saying.
Yeah.
So one of the issues is that the vaccines are manufactured in the Midwest. They're manufactured right now in Wisconsin and Michigan. And that's going to slow down transportation of those vaccines out of there.
Yeah.
Although the J&J is being manufactured in Baltimore, so people are going to want to come up to Baltimore and stand in line, I guess. I don't know.
One thing I think it's important to say, it's obvious, but I'll say it anyway, is we shouldn't get upset with the local public health departments or the people who are just trying to put the shots in our arms. They're dealing with whatever they have. They're dealing with the rules, the groupings, and with the supply. And I think sometimes people get upset with the messenger, so to speak. I think they're doing the very best they can. I remain optimistic because of seeing, without being political, seeing some changes in the government's willingness to do some federal coordination of things and to pour more money into buying doses. So here's a question that fits under the category of pandemic fatigue, and I think is a very important question that I've heard from my employees, my colleagues, my family, and from my own heart. Starting to wonder if this will ever be over. Vaccinated people should wear masks. Vaccines will lose their efficacy after some time. Variants. So is this permanent? Will we ever be unmasked? And let me just add one little twist to that. We know that we've had a very mild flu season this year. We've been away from each other. We've been wearing masks. Would we be good off to change some of our social habits so we shake hands and hug and kiss each other like crazy? I have friends from Eastern Europe that kiss me 3 times on the cheeks and so on. Would we be smart to try to think about different social mores in that way? So 2 questions for the wisdom here. One is, will we ever be done with this particular thing? And secondly, should we rethink some of our social customs because infectious diseases will come? So please, if you guys can't answer those simple questions, I don't know what. Manya, can you start?
I really think we should look outside of our, United States lens. There are other countries where people wear masks all the time. They wear them because of pollution. They wear them because of infectious diseases. I personally feel like we've all invested heavily in our mask wardrobes. So maybe not in a hospital, but I have a lot of beautiful masks with flowers and whatnot. And I do think that I will continue to wear a mask when I'm outside my house for the foreseeable future. So I think we do need to change that. And I think the other things we're going to have to, get used to, but I do think we will be in groups again. I do think this will end. And people are using that idea like, oh, well, why should I get vaccinated? I've heard this a couple of times. Why should I get vaccinated? Because I still have to mask. But like masking is not a full protection and getting a vaccine is much more of a protection. So really try to reduce your risk and just do it all and take it in stride and say, this is where we are now. And maybe we'll be in summer soon and going to picnics and it'll be fabulous in your mask.
I love that. Richard?
Well, I think we have to look at history. There have been pandemics over and over again in many centuries. They do end. And the problem is that we don't know how to predict when it will end. It's going to end. There's no doubt it's going to end. This virus will mutate, hopefully in the right direction sometime soon, so we don't get as sick from it. But, I think our social norms are going to change. Really, it's just when you watch a television show and you see people congregating together that was made before 2000, you kind of wonder, oh my God, did we really do that? Did we really congregate? I saw somebody shaking hands on television. I said, no, you don't do that anymore. So, I think this is long enough that a lot of this will be ingrained. So I think when you get into Leah, you aren't going to go up and kiss the rabbi anymore. You may bump elbows, but that's probably going to be relatively permanent, as permanent as things can be in Judaism, but that's probably what's going to happen.
Beautiful. Now I have a little sort of a crisis of conscience here. I got almost simultaneously a question for Rabbi Zemel and a question from somewhere else. I want you to know I'm going to go for the someone else person because the rabbi is going to have the last word, but you got to stick up for me in case I get punished for this. This is a great question, a really good question. Inequity in access to the vaccine is a global problem. What can be done about getting vaccines to countries without the resources we have? I want to make one quick comment. Again, it's not meant to be political. I am so encouraged that we're going to be involved with the World Health Organization again, because pandemic anywhere is a pandemic everywhere. That's the way the world works. But you've thought a lot about this, I'm sure, Manya. Please give us your wisdom on this. You've thought a lot about these things.
I absolutely agree. I'm so happy that we're back into conversations and cooperation with the rest of the world about public health. It's critical, as you said. I mean, the virus does not care about a boundary or a border. We are on planes, we share everything, we share our pathogens. So we have to consider it a world community. And I really feel that we have a real obligation to ensure that we get vaccine not only to different zip codes here in the DMV, but we do to other countries in the world, and we have to chip in and figure out how to support that. I think there's a lot of ways to do that are very creative people working on this problem. And just like we have generic drug pricing around the world for practically everything else, and we support that by paying for more expensive prices here in the United States because we are higher resourced, I think we're going to need to take similar approaches because we need to stop this virus from everywhere. And that will promote equity. But I think there's other ways also of thinking about this, and I'm trying to work very hard myself. We have these variants that have been designated from places like the UK variant, and one way we can even start thinking about it collectively, I'm sort of leaning towards saying, a place doesn't own a variant. We all own that variant, and it's B117 or whatever the notation is. And I think we all have to open our eyes to the fact that this is not a nationalist problem. It is a global problem. So I'm very encouraged though by what's happening now.
You're right about the naming of the variants. I mean, the World Health Organization was very careful not to call this the China virus or the Wuhan virus, and to give it a non-political, non-geographic name. And so, we've slipped back. I mean, it really is a slip. So you're absolutely right about that. My only hope is that, I'm rooting for the Russian and Chinese vaccines to be effective. I mean, that's going to be the only way around this. They're going to serve the bulk of the population of the world. And, the United States is not trusted in every country in the world. And clearly China has made inroads. Russia clearly has made inroads. And we can only hope that those vaccines really live up to the expectations.
By the way, before I ask the very last question, to your passing mention, Richard, of the so-called China virus, there have been, we're always looking, especially Jews, are always looking for evidence of unfairness everywhere. It's part of our thing. And there's been a lot of increase in anti-Asian incidents, words, violence, you name it, as if it was somehow their fault that a zoonotic disease jumped from animals to humans. Okay, here's the last question, lovingly crafted between a question the rabbi asked and somebody else asked, so everybody gets credit. But we're going to have to wrap after this and turn it back to the rabbi and Deborah. So here we are. The question coming up about how long, again, a variation of a question you already answered in your presentation, Richard, how long the efficacy of the vaccine is at a level that will help us maintain herd immunity. Your best guess as to whether, regardless for a moment of variants, of mutations, will we end up getting boosters, even if it was the same strain, periodically? And what's your best guess as a doc taking care of kids, doing all this wonderful stuff, you and Manya? Will it be a once-a-year deal? Will it be a twice-a-year deal? What's your best guess? understanding it's a guess. Richard and then Manya.
I'm going to guess at least once a year, probably twice a year. And hopefully it will, and it will be a booster. So it will be one time at that level. We do this with babies. Babies get boosters every 2 months for the first 6 months of their life. So we do this to our infants. We really could do it to ourselves to protect all of us.
Manya?
Yeah, I think we don't have the data, and if I had to guess, I would totally ditto what Richard said. I don't think we really know, but that's obviously under study. It's really important. But I think that's like an access point. We could just going back to the inequities. If we say, we've always historically had flu shots where we could get more people to flu shots, get them into COVID shots, take their blood pressure and do some primary healthcare linked to the vaccine, really get rid of some of these barriers and try to make it so that this is a focal point of sharing access. I think that we could leverage, if it's every 6 months, every 3 months, every 18 months, we're just going to have to do it, and they're going to tweak the vaccine, and it's going to work, and we're going to be okay. So that's my hope, at least.
Well, listen, let me start by thanking the panelists. You guys are fabulous. The formal presentation was to die for. The answers to the questions, especially ones where you had to sort of sneak around and tell people you don't really know, or it depends. You did it very artfully. It was beautiful. And all three of us want to thank everybody who attended tonight. These are great questions. We got to about 80% of them. I think the sense of all of them had a chance to ask. And Richard and Manya, thank you very, very much. You're the best. And Rabbi Zemel and Deborah, back to you. Thank you very much for letting us be a part of this tonight. Rabbi, over to you.
Thank you so much for this wonderful, informative conversation. We really do rely on you to help keep our community educated, and you infuse us with a certain degree of self-confidence. I want to make one comment about something that Dr. Katz said, and I can call Dr. Katz Richard Katz because, as many of us know, Richard and I go all the way back to high school together, so high school years. Richard made a comment that you may not be getting when you go up onto the bima for an aliyah, you may not be kissing the rabbi, to which I put to the chat box, just to Richard, that solves one future system of honoring at Temple Micah. As of now, Louise Zemel is going to get every aliyah at Temple Micah, and that problem will be solved. But so thank you all very, very much. And as David said at the beginning, Deborah, take us home.
Hoping we'll all pull through, hoping we'll all pull through, hoping we'll all pull through, me and you. When we look and we see things are not what they should be, God's counting on me, God's counting on you. When we look and we see things are not what they should be, God's counting on me, God's counting on you. Hoping we'll all pull through, hoping we'll all pull through, hoping we'll all pull through, me and you. There's big problems to be solved, let's get everyone involved. God's counting on me, God's counting on you. Big problems, there's big problems to be solved, let's get everyone involved. God's counting on me, God's counting on you. Hoping we'll all pull through, hoping we'll all pull through, hoping we'll all pull through, me and you. Don't give up, don't give in, working together we all can win. God's counting on me,